Hello, YouTube. I am Hans Gao, a fourth year medical student at Northwestern. Today, I'll just be going over some pulmonology questions for the Step 2 CK exam. Specifically, I'll be going over some questions that I have gotten wrong in the past pertaining to pulmonology knowledge. Pulmonology can be a tricky subject for many people because the differences between the diseases can be very minute. It's a very subtle field, and knowing the small details can mean the difference between knowing what the next steps are and being completely lost. So, without further ado, let's get started. All right. First question. This is a kid who came in with bacterial with a croup, and it asked what the next best step in management was. I got this question wrong because I confused the management of epiglottitis with the management of croup. So epiglottitis, you intubate immediately, whereas for croup, you give albuterol as well as epinephrine. Um, I think I just haven't encountered this question in a while, so I got it confused. It makes sense to me that very rarely are children actually intubated. So it makes sense that they would only be intubated for something that is exceedingly rare, such as epiglottitis, especially in this, especially when there are available vaccines against Haemophilus influenzae. Next question. All right, so this is a diagnosis question. All right, so this is a patient who has undergone a lung transplant, immunosuppression, vitals look fine. All right, PFC and FEV1 are both pretty low, and the FEV1 over FVC ratio is pretty high. Not drastically so. I think usually like 70 or 80% is typically the cutoff. Um, but yeah, these are values that would be at least somewhat concerning. BAL shows no organisms. Which one of these is the most likely diagnosis? Given that this transplant happened 5 years ago, I'm really thinking about some kind of rejection. Specifically, it could present with an obstructive pattern because you're destroying the airspace. You're destroying um, the alveoli of the lung. Let's take a look at the answer choices. BO, no, she's not a smoker. This is exclusive in smokers. Chronic PE, kind of doubt it. She doesn't have that many risk factors for it. And it also wouldn't cause this type of a picture. Emphysema, yeah, possibly. Uh, but she's not a smoker and she doesn't have that liver disease that gives you emphysema, so I doubt it's this. Hypersensitivity pneumonitis is also kind of unlikely. She doesn't live on a farm or anything. Pulmonary edema. Not sure, it could be. Pulmonary fibrosis. Fibrosis would kind of lead to decreased FVC and FEV1. Um, and FEV1 over FVC ratio would be around like 70-80%. Um, oh boy, this is kind of hard to say. Damn, these questions are harder than I remembered. Physical exam shows clear lungs. Um, Given this, yeah, I'd say I find that pulmonary edema to be a bit less likely. I'm still thinking whether or not this could be chronic PE. Having it for one entire month seems kind of bizarre to me for chronic PE. Oh, you know what? I made a mistake. So I was thinking about TO, thromboangiitis obliterans. This is bronchiolitis obliterans. Um, this makes more sense to me because I don't think either of these are going to be quite likely. Yes, I'm going to go with BO, and it is the right answer. Yeah, so I guess the moral of the story here is do not confuse BO with TO. Yep, and this is a pretty classic obstructive pattern you see here, especially with the FEV1 FVC ratio. That's going to be a pretty high note for the exam. It tends to be for obstructive diseases, I think 80, 75, or it's less than 80%. It's in obstructive disease, this ratio is low, and it's in restrictive disease, that ratio should be normal or even slightly elevated. All right, here we have a pretty long question. It's a management question. Uh, 5 days ago, so this is kind of in that PE period. This increases the risk of pneumonia. She is on heparin. All right, so this is decreased breath sounds over the right base. So this is kind of atelectasis, and the temperature is kind of borderline for that. Okay, yeah, so a chest X-ray shows a right basal atelectasis. Which of the following is the best step in the management of this patient? It's pretty clear to me that it's because she wasn't using the incentive spirometer. And you want to keep the lungs open by applying some kind of pressure. You wouldn't give antibiotics prophylactically. D-dimer is not going to be useful here. You're not really looking for a PE. Could she start on a PE? She's already on prophylaxis, and then there's this chest pain makes it look like she might. However, yeah, I don't think PE would show up as atelectasis either. Analgesics, no. If she had a broken rib, maybe yes, but otherwise no. I initiate positive pressure ventilation. Maybe. Yeah, you could definitely go up on this. She might benefit from ventilation. That's definitely true. Given how severely short of breath it is, though, it seems kind of strange to me that this would only be atelectasis. Also, it's like 5 days from the surgery. In this kind of setting of, in this kind of setting, I think the question is how high is our suspicion for PE? This is just post-surgical setting, but I still don't really feel that my suspicion is too high. Um, Yeah, I'm going to go with positive pressure ventilation for this one. And no, I was wrong. Oh, I forgot that she had cancer. So if you include cancer, then I mean, I guess she doesn't technically have it anymore. But okay, I guess both surgery and cancer are independent risk factors. All right. A prophylactic dose may reduce the risk of PE, does not eliminate the risk completely. Well score is 7, 1.5 for tachycardia, 1.5 for risk of surgery, 1 point for cancer, and 3 points for PE being more likely than other diagnoses. Yeah, this part I forgot. And also the recent surgeries. I actually did this in my head. I only had two and two and a, I mean, sorry, I forgot the, yeah, I only had like a score of 4, which is like you get a P, you get a D dimer, but that's not going to work in the post-surgical setting. Oh boy. Atelectasis does not cause chest pain. All right, so yeah, the chest pain and me forgetting about the cancer and the Wells criteria has kind of screwed me for this question. I should have remembered it better. All right, this is a young child. Wow, look at that. Look at those airways. That's cool. All right, 30-year-old boy, NICU. Mr. 30-minute-old boy. All right, 32 weeks, so not too bad. Got glucocorticoids and everything. Right, so what we have here is a case of hypoxia that improves with oxygen administration. In this kind of setting, it feels it's less likely to be a cardiac problem, since if there were an issue with the blood vessels, you increasing air, you putting more air into the lungs wouldn't really fix that. The blood is still bad. It's not going to be coarctation. It's not going to be transposition of great arteries because oxygen wouldn't help with either of those. Respiratory distress syndrome, I can kind of see that. Persistent pulmonary hypertension, I can kind of see that too. He developed cyanosis a few minutes after delivery, so yeah, I can see that. Transient tachypnea of the newborn, no, this is not it. You wouldn't have those DSATs. Um, I don't think he's young enough for NRDS, quite frankly, and given that they pulled all the stops on him, and this doesn't look too bad. So I don't think it's NRDS. However, I do think this could be a persistent pulmonary hypertension. Blood's just not getting into the arteries because there's so much fluid. Um, yeah, and once you give the oxygen, that kind of pushes out the fluid, and then the blood goes in, and then everything's hunky dory. And I'm wrong again. Wow. Pulmonology is not treating me well today at all. So this is respiratory distress syndrome. Pete's poem. I need to review Pete's poem. All right. diffuse ground glass opacities and air bronchograms. Okay, so this typically means that there is fluid, not in the bronchi, but in the alveoli only. Not sure what it has to do with anything here, though. Surfactant deficiency, tachypnea, grunting, hypoxia, cyanosis, vasoconstriction of pulmonary vasculature, air bronchograms. Okay, so air-filled bronchi surrounded by atelectasis. Okay, I guess I didn't know. I kind of misunderstood the meaning of air bronchograms. This just means that there's kind of diffuse atelectasis. So persistent pulmonary hypertension shows a normal chest X-ray. All right, fair enough. Yeah, Pete's poem, guys. It's not simple. Don't get cocky about it. Adult patient. This is about pasophys. All right, this is a pressure problem. Cardiac index is fine. Right atrial pressure is fine. Pulmonary capillary wedge pressure is also fine. Systemic vascular resistance is decreased. Which of these are following additional finding in this patient? So this patient sounds very septic to me, and given these findings, the heart itself is okay. It's just that there is so much third spacing that's going on in here. So which of these are kind of associated with third spacing? Um, Bounding pulses. Now this is aortic regurg. I'm not really suspicious of that here. Systolic ejection murmur. So this is aortic stenosis, not regurg. Cold extremities you can see in cardiogenic heart failure. This is not it. A cardiogenic shock. Distended neck veins, again, this is cardiogenic shock. Pulsus paradoxus. You see this in what, like severe asthma, pericardial effusions, and that kind of thing. It's not going to be seen here. Third heart sound. Yeah, so like an S3 or, yeah, most likely a S3 murmur. What you can see, what you're seeing just in general in hypervolemia. Yeah, so kind of looking back, the cardiac output is still pretty high, which I find kind of odd. Maybe it's not quite septic shock yet, but the person's increasingly becoming septic. And maybe the nursing home just put fluids into her trying to fix this issue. That explanation would make sense to me. And in that case, you would hear a third heart sound. Cold extremities is kind of a tricky one. Yeah, you're third spacing so much, so I guess it could be cold. You're not like, you're still perfusing it. You're not perfusing it super well though. Yeah, I think you will be warm and wet in sepsis. So I'm gonna go with third heart sound. Third heart sound. God damn it. Septic shock. So I was right about septic shock. Compensate for intravascular hypovolemia, the cardiac index and stroke volume increase, leading to increased pulse pressure. The pulse pressure is only like 40. Oh wow, this is an entire phase of sepsis too, the hyperdynamic phase. Okay, I guess that's good to know. I ruled out this answer choice way too quickly. Um, yeah, I thought this was referring to aortic regurg, especially given that murmur. It seemed like something that the NDME would do. It seemed like an obvious trap answer, and in the end, it turned out not to be a trap answer. Yeah, the third heart sound didn't really make sense to me either, and for the reasons I discussed earlier. Wow, this exam is it's not easy. I need to review this. All right, which of the following are most helpful in differentiating asthma from COPD? So asthma is obviously reversible, COPD is not. All right, so what could be helpful here is like you can either use like a methicillin challenge, which can worsen asthma drastically, or you can give some kind of albuterol and see how well they do after that. Um, yeah, so kind of X-rays now they will show hyperinflation, amplifying antitrypsin. No, unless you have that specific deficiency. IgE measurement. This could be elevated in asthma, sure, but again, I don't think this is commonly done, and it wouldn't really show you much of anything. There are like IgE-mediated variants of asthma. However, this is not really super specific for this. You wouldn't use this to kind of measure all asthma forms. Before and after inhaled bronchodilator, this is the one I'm leaning towards. Serum eosinophil count. Again, this could be increased in asthma, but not always. Um, and this would you'd also see this in what like bronchiectasis and such. Symptomatic response to a trial of albuterol. No, I guess you could, but spirometry will give you a much better answer and it's more quantitative and objective with delta. And this one I did get right. Woohoo, finally. Reversibility of airflow obstruction. I think I got it wrong the first time, maybe because I misread the question. Um, yeah, well, it was updated pretty recently too, so maybe the question was kind of phrased in a bizarre way before. IgE eosinophilia are maybe present but are insensitive and nonspecific. Yeah, that's what I thought. Management question. Guy stabbed in the chest. Respiratory distress. Breath sounds are present on the left and absent on the right. It doesn't actually say where he got stabbed. Okay, neck veins are distended. Patient becomes obtunded during exam. Which of the following is the next best step in management? Yeah, hemodynamics are crappy. Uh, I have a strong feeling this guy got some kind of tension pneumothorax here, since especially neck veins are distended. Um, yeah, and you do not get a chest X-ray for these cases to confirm it per se. You just do it. You just immediately you have to decompress the chest. Thoracotomy, you wouldn't go that far unless like maybe if needle doesn't work, you go into the full thoracotomy. Otherwise, there's no point. Pericardiocentesis. I guess if you got stabbed in the heart and had some kind of pleural effusion too, like some kind of tamponade, maybe, but this picture doesn't sound like it. Rapid fluid resuscitation, no. I think I got this. Yeah, I got this question wrong because I actually chose intubation the first time. Now, airway, breathing, circulation. However, this is one of the few exceptions to that. Decompression needs to be performed prior to intubation. Yeah, so if you intubate, there's going to be additional buildup of pressure inside that intrathoracic space, and it's going to be even worse. All right, next question, peds again. Diagnosis question, noisy breathing. He gasps for air while sleeping, okay? All right, so picture to me is kind of unclear. It seems like maybe he has some kind of a obstruction or OSA. And typically in children, it's because of hypertrophy of the tongue and all the muscles that are back in the throat area. It's not allergic rhinitis, different set of symptoms, asthma, no, uh, coin, coa, choanal atresia. That's a different set of symptoms. They turn cyanotic when feeding and all that. Actually, could it be? Does he breathe through his mouth? I'm going to keep it on there for now. Laryngeal Malaysia, no, you have that at Strider at rest as well. OSA, we're considering vascular ring, be gagging a lot more. And notice how much it says noisy breathing too. It never says that he actually stops breathing. Yeah, so kind of in this kind of scenario, he doesn't seem like apneic. Um, he's kind of breathing through his mouth, so I'm thinking there's some kind of atresia in this area. Maybe not like full atresia, but partial. Nope, I overthought it. Upper airway, apnea, gasping for air. Yeah, adenotonsillar hypertrophy, right? Adenoid hypertrophy. Okay, I see. So because this is not really related to relaxation of the muscles, the children need to breathe during their using their mouth during the day as well. All right. So why did I get it wrong? So choanal atresia, I guess it just happens in neonates more, and I guess there's no such thing as partial atresia. It's just like where stenosis is either you have it or you don't. All right, fair enough. I see that unilateral can occur during childhood, but presents with chronic nasal discharge rather than difficulty breathing. All right, so that's pretty. I think I have to remember that, obviously. But damn, this exam is just wrecking me left and right. It's not good. Most appropriate next step in management question. Gunshot wound, post-op fever, hemodynamics are crap, febrile. Sounds like pneumonia-like picture. Urinary output is also crap. Yep, very obvious signs of infection. All right, this is going to be pretty important here. He's pretty acidotic, and he is trying to compensate for that. He's not getting enough oxygen, though. All right, yeah, so pretty typical picture. Next step of management, yeah, so you just give antibiotics. And I believe you'd also just give fluids to just try to clear, given that he's kind of septic and his kidneys are failing, you'd want to kind of protect against that. What is this albumin? Albumin's kind of low. So would I give albumin? I don't know if I would. All right. No real indications for dialysis here. Yeah, saline makes sense to me. IV albumin infusion, uh, not less likely. IV dopamine, no. We're not. Our goal is not like the pressure doesn't really concern me much. Hydrocortisone, no. The adrenals are fine. Yeah, no signs of adrenal issues. Um, Bicarb, no. You give this. You rarely do ever give this. Um, RBC transfusion, no, it's not so bad that I would transfuse him. Yeah, so I'm pretty sure I just go with normal saline here, just kind of give him some fluid support, and this is what you do in sepsis. Good. All right, so I'm getting the easy questions right, and I think I overthought it before when I said I think before I vaguely remember this question. I think I selected giving albumin last time. Uh, Albumin's just more costly and harder to get, so you pick saline. Also, I think there are restrictions on how much albumin you can. There is like more restrictions on how long you can administer albumin and such, whereas saline you can pretty much give it indefinitely. So saline will be the better choice here. All right, we're at question 10. All right, management question: 33-year-old woman, postpartum setting, discharged 4 days ago. All right, it's kind of first one was a PE picture. Tech, uh, yeah, so C-section, post-surgical setting. Tachycardic, tachypnic, obese. ABG shows, yeah, she's alkalotic because she's breathing super quickly, as people do in PE. Carbon dioxide is always going to be low here. It's just because you're ventilating so quickly, and even if you're out one lung, if you breathe fast enough, you're still going to be alkalotic. However, you're not going to get enough oxygen, which is what we see here, bicarbonate. In addition to supplemental oxygen, which are the best is the best initial step in the management of this patient. The lower extremities are lower extremities. Doesn't really say anything about lower extremities. But yeah, my suspicion for a PE is pretty damn high. Yeah, I could get a CTP on this patient. D-dimer is useless in the post-surgical setting. IV heparin. Actually, I guess another thing this question could be testing me on is, if your suspicion for PE is high enough, do you just treat and give heparin first before you go for a CTPE? That would make sense to me actually, so I'm going to leave it there. No, this is too late for that. Echo, no. Troponin, I'm not suspicious about heart issue at all. Echo, no, I'm not concerned about a cardiac function issue. Yeah, so it really comes down to do I start heparin now or later? Heparin first or a CT angiogram first? Yeah, you know what? Given that this patient's kind of acutely ill and these vitals are kind of bad, I want to give something for treatment immediately. I don't want to wait for diagnosis, so I go with IV heparin infusion. Oh, hey, look, I'm in the minority, but the minority was right. So PE is super likely, and the clinical suspicion for PE is so high that you are absolutely sure this person has a PE. start anticoagulation as long as there's no contraindications. And obviously, you can stop it later if if the patient ends up testing negative for PE. But yeah, I guess that's a very important lesson. Step two loves to test on this type of thing. Step two loves to test on whether you can just clinically treat empirically, or if you need to confirm the diagnosis before you treat. Um, and in this case, PE, I guess, is one of those conditions that you can treat based on your clinical intuition. And it makes sense to me because this is such an acute issue that you should not wait to confirm the diagnosis. It's kind of like tension pneumothorax. If you suspect it, just go and treat it. Yeah, and heparin is such a low risk. And heparin is pretty low risk, especially IV heparin. So it's yeah, so it's safe. Pathophysiology question, hemoptysis. Oh, coughing up lots of blood, epistaxis, all that good stuff. All right, I'm not really sure what this is. Could be he has like a genetic problem with a lot of AVMs, especially given how long this has been going on. If it doesn't tell me about the Brui and his childhood history, I'd be more concerned about some kind of autoimmune disease. But yeah, it doesn't seem like this. He's not septic. Uh, yeah, this wouldn't cause a Brui or his pediatric history. Disseminated tuberculosis. No, it wouldn't cause epistaxis. And it's not going to really cause microcytic anemia. Yeah, so I'm going to go with AVMs for this one, especially with the faint continuous buoy in the right infrascapular region. This kid might have cancer or some kind of infection. This is like a kind of painting a classic picture of um, hereditary telangiectasia for me. Yeah, so I'm going to go with alpha. Good. Yeah, lots of AVM, some offices, right side of heart failure. Good. Oh, this is interesting. So AVMs apparently look like nodules on chest X-ray. Okay, that's cool. Etiology question. All right, seizure, fracture. He's confused. Vitals are okay. Oxygen saturation is kind of low. Is disoriented but no focal weakness? All right, so yeah, I'm thinking this is some kind of fat emboli syndrome versus sepsis versus DIC versus um, some other lung condition. All right, so this person's breathing very quickly. not getting enough oxygen, but still able to vent out air. Bilateral scattered ground glass opacities, but no filling defects. All right, so that was OPE. Which of the following is likely cause of this patient's condition? Yeah, so scattered ground glass, ARDS, pretty non-specific finding ARDS or any type of inflammation, really. Um, aspiration pneumonitis, yeah, I'm kind of concerned about that, yeah. Um, not really super likely to cause bilateral ground glass opacities, but possibly. Cardiogenic pulmonary edema, no, it'd be way different. Drug-induced hypersensitivity reaction, I doubt it's going to happen that quick. It's not like it doesn't seem like an airway issue to me, and he's not having any rashes or anything. Yeah, so it's kind of unlikely to me. It's less you're not it's also going to not present as confusion. Fat Ebola syndrome, again, possibly. Really hard to tell. Pulmonary contusion. You could get lung injuries, sure, and I think it could cause ARDS later on. However, I'm not really sure if you'd see, and it would be delayed, but I'm not sure if you would be delayed by this much. Patient is disoriented. I don't know if that's sepsis/delirium or if it's actual like fat emboli syndrome or the fact that he had a seizure. Also, don't know if fat emboli syndrome could present this late. It's like one day afterwards, so I really don't think this is going to be it. Furthermore, there are no skin changes. Pulmonary contusion, I feel like it's less likely to kind of affect both sides, especially given that he fell to the right. Yeah, gonna go with aspiration for this one. All right, so I got this one wrong. This is fat embolism syndrome is present 42 hours. Oh wow, so I completely messed up the timeline. SES does fat embolism syndrome does present a full day or 3 full days afterwards. Damn it. Yeah, I know it's like for the rash, and the rash is not really super common. So they also get ARDS. ARDS is kind of like the common endpoint, so yeah, you really can't anchor anything off of that. Aspiration can lead to ARDS as well. However, less likely in the absence of fever and leukocytosis. Okay, fair enough. Thrombocytopenia would be unusual as well. I didn't even notice it's thrombocytopenia. But you know what? I guess it makes sense. Microvascular dysfunction. Pulmonary contusion. Local causes local pulmonary edema. It does not really cause ARDS. Okay, so I guess that's good news. Yeah, or as long as it's more resilient than that. It's not really damaging the alveoli per se of pulmonary contusion, so it doesn't make sense that ARDS would occur. So that's intuitive. I got this one wrong in summary because I completely messed up the timeline for fat embolism syndrome, and I was not thorough enough when I was looking at the labs. I didn't highlight the thrombocytopenia part and the absence of fever. Management question, chest x-ray, nodule, remote smoking history, but a lot of it. All right, so not a super big tumor, but I guess kind of suspicious. Borders are irregular, although there are no calcifications. The lack of calcifications is reassuring. No other lung lesions or large lymph nodes. All right, so I don't think it's tuberculosis. And, like, he doesn't really have a history for that. He'd be febrile, and there'd be more findings. Cytology, we could, but I don't really think this is going to show anything on cytology. Reassurance doesn't seem like the right thing to do. You'd at least have to repeat it. Repeat CT scan in 3 months. Maybe, I don't know. Would you surgically excise it? I guess I kind of have at least like an intermediate, not a super large one, but yeah, not like a super high suspicion. It's not a super large tumor either. Peripheral round, right lower lobe. Yeah, this is not super low suspicion. If you said like regular borders or if it's like 1 centimeter, I probably would just say repeat it. But 2 centimeters irregular border, I'd do surgery. All right, good. Got this one right. So the cutoff here is really strict, 0.8 centimeters. Require additional management or surveillance. All right, good stuff. Pathophysiology question. Cholecystectomy. ABG looks crap. Vitals look good, but oxygenation is bad. Really acidotic. Oops. Really acidotic, and she's not really compensating for this acidosis. She's retaining carbon dioxide like no other. Yeah, so she's on a hydromorphone, and her respiratory drive seems like it's low. It's not going to be acute. So yeah, I think it's like some kind of a alveolar hypoventilation. Atelectasis, you wouldn't see so many changes. Pleural effusion, no, wouldn't happen this quickly. Pulmonary edema, again, one, it's not likely to be this acute, and number two, I feel like there's no good trigger for something like this. Atelectasis too, you'd be more likely to see a fever. Acute pulmonary embolism, this is what, second post-operative day, so yeah, not very likely, and also no real other risk factors. Yeah, overall, this is a pretty clear picture for alveolar hypoventilation. I was afraid for a moment it'd be atelectasis. However, atelectasis, the gradient's elevated. There's a decrease in PaCO2 due to compensatory tachycardia. Okay, so I think that one thing that's kind of interesting here is that in COPD, there's carbon dioxide trapping, and in atelectasis, there is no carbon dioxide trapping. What this kind of means is that even when you have post-surgical atelectasis, there's enough of your lung functioning that you are still able to ventilate yourself and get rid of carbon dioxide. Not sure why I got this question wrong the first time I did it. Maybe I was tricked by the atelectasis answer, but she's afebrile and it's not really likely. Pathophysiology question. 38-year-old, dry cough, malaise, hilar adenopathy bilaterally. All right, so this is kind of like a painting a pre-classic sarcoidosis picture to me. Let's go with the answer choices. Bronchospasm, no, you wouldn't have it for 2 entire months. Chronic granulomatous inflammation, yeah, kind of, yeah. Loss of elastin in the lung matrix. Loss of elastin, I think that gives you fibrosis, right? But yeah, it doesn't look fibrotic. It's, if anything, it looks hyperinflated. Necrotizing pulmonary vasculitis, low, no. Coughing up blood, no other symptoms. Pulmonary venous congestion, no heart failure. Recurrent PE. That wouldn't explain the adenopathy, and she's not really at any risk factors. Yeah, so this is I'm pretty sure this is sarcoid. Yeah, this is a sarcoid. Yeah, not sure why I got that one wrong the first time. Maybe I was just being careless. All right, next. What's the father's most likely diagnosis? Diagnosis question, 37-year-old, coughing up blood, pain, blurred chest pain, thick brown sputum. That's not good. Oh wow, pretty high risk patient too. AML, graft versus host disease, found the host vein, neutropenia, temporary venous cramp. Yeah, these leukocytes are pretty bad. Yeah, hematocrit's also pretty bad. Right upper lobe infiltrate, several nodular lesions with surrounding ground glass opacities in the right upper lobe, shows inflammatory cells but no organisms. All right, that's interesting. Which of the following is the most likely diagnosis? All right, so we have a lot of different possibilities for the infectious, what's causing this infection. So let's kind of go through all of them. CMV usually, like in transplant patients, kind of causes lobar pneumonia. Yeah, it doesn't seem super likely to be here. Invasive candidiasis, you'd see something on I feel like you'd see something on gram stain for that. Pneumocystis jirovecii, it doesn't really, this is usually a diffuse disease in very badly immunosuppressed people. This doesn't see, I mean, obviously this person's immunosuppressed, but yeah, it causes changes in more areas. Pulmonary tuberculosis, no, it doesn't seem likely. We'd also see something on the sputum. We'd also see something on the sputum ram stain. Could it be aspergillosis? What do they take for the ram stain? That's my question. Did they do it like, I guess they probably did it BAL. I feel like you'd see that on the gram stain though. So it kind of leaves me with these. Yeah, all of these are either fungi or yeast or some kind of protist. Like this is the only virus one. And you know what? I think this is a virus. I'm going to go with alpha. Hmm. I second guessed myself. I got it wrong. The answer is aspergillosis. Huh. Oh, and this is invasive aspergillosis too. So I think I might have gotten it confused with chronic pulmonary aspergillosis and like chronic bronchiectasis and such. BAL with biopsy and are required. Biopsy are required if non-invasive testing. Sputum. Oh, it was from the sputum. Oh, God damn it! I completely misread this. Yeah, if I'd read this, I might have changed my answer. I guess CME this doesn't produce that halo sign. All right, so either you know this question or you don't. This is referred to the halo sign, and only aspergillosis has that. I did not know that. I think I actually kind of suspected it, but I talked myself out of it. Second guessed myself. So yeah, just need to make a stronger mental note of that. All right, this is probably going to be the last question for this part. Empiric antibiotics question, treatment question, 6-year-old cystic fibrosis patient. Respiratory distress, infiltrates, influenza testing is positive, cefepime and also tamiflu. Which of the following antibiotics should also be administered in this patient? All right, so I think for children, well, in cystic fibrosis, we're concerned about staph, strep, and also Pseudomonas. And I think in children, staph is more common, whereas in sorry, in children, strep is more common, whereas in adults, Pseudomonas is more common. Let me just double check that. Damn, like these are all scientific papers. I don't have time for that. This is annoying. Alright, so this is annoying. It seems like this is pretty well known clinical knowledge, but I just can't really find any definitive answers on what I would like to see. That's annoying. Alright, 6-year-old, I'm pretty sure we're concerned about strep, maybe staph as well, given that he's been in the hospital for so long. Cefepime and also Tamiflu. All right, good. Cefepime Yeah, suffocating covers Pseudomonas, so that's good. That's covered. I'd also might want to add something about MRSA or strep. Um, Itraconazole, no, that's not going to do anything. Nafcillin, that could cover. That could cover. Wait, suffocating should cover strep too, actually. Yeah. So I guess I'm just concerned about MRSA then, um, or just Staph aureus. Given this kind of hospital setting, um, multiple hospitalizations, I'm kind of concerned about MRSA, so I'm going to go with IV vein. Amoxicillin, not really. This is not atypical pneumonia. Sorry, is this or no? Amoxicillin covers gram. Yeah, not super concerned about amoxicillin here. Cipro, no. Don't get that for children. Good. All right, so this is a one that I got right, but I kind of missed like a pretty important question, which is staph is most common in young children, uh, whereas Pseudomonas is more common in adults. I wonder why that is. I guess one is probably because children just get sick a lot. They get flus and colds a lot more often, and staph loves to colonize after viral infections. Staph also lives in the nose, whereas I don't think Pseudomonas is typically found in the body. You can almost think of it like maybe children pick their nose and get viral colds all the time, whereas adults go to hot tubs all the time and get Pseudomonas folliculitis. So, yeah, got the question right, even though my reasoning was kind of wrong. All right, so I think that's going to be it for this part of the recording. I'm going to make another recording covering the second part of this test.